Okay, thank you, Jason. Good morning, everyone. I'm Jen Cook, and I'm very excited to welcome you to the first grand rounds of the 2022-23 academic year. And usually it would be our department chair welcoming you, but I'm standing in because guess what? Our department chair, Dr. Kim Williams, will be the speaker today. Just a quick reminder to everyone to put your name in the chat so we can record your attendance. And now I'm going to turn it over to Dr. Dinesh Kaura, who is the division chief of the Division of Cardiovascular Medicine, to do a proper introduction of Dr. Williams.
Thank you, Dr. Cook. It is indeed my honor to introduce Dr. Kim Williams, who all of you know is our new chair of medicine, to give this academic year's first Department of Medicine grand rounds. So first, I just want to say Dr. Williams really needs no introduction. He's known across the world for his passion, for his advocacy and work that he has done on the promotion of plant-based nutrition and eliminating disparities in healthcare. So the title of his talk today is actually going to be very apropos of his tremendous efforts over the past 2 decades in raising awareness and in advancing the science and implementation in these fields. He's often fondly called the vegan cardiologist, and he's a much sought after speaker and a brilliant scientist and clinician. He completed his medical school at the University of Chicago, followed by his residency in medicine at Emory in Atlanta. And then he served a cardiology fellowship at the University of Chicago. He's served many leadership roles, too numerous to really elucidate here and do justice properly. So I'll just give you the highlights. He's a past president of the American College of Cardiology in 2015 and a founding member and the president of the American Society of Nuclear Cardiology in 2004. And we were lucky to snag him from Rush University in Chicago, where he served as a James Herrick Professor and Chief of Cardiology and the Associate Dean for Faculty DEI, and where I had the pleasure of working with him under his leadership for over 8 years and learning from his wisdom and thoughtfulness in clinical problem solving, as well as in policy making and leadership. He's a prolific academician with over 300 publications and multiple book chapters and guidelines. And he serves as the editor-in-chief of the International Journal of Disease Reversal and Prevention. We're very lucky to have him as his new chair, as our new chair. And already in a couple of months, we're feeling the impact of his leadership style and his effectiveness. It's just very palpable in our department. So with that, I'm going to turn it over to Dr. Williams for a very insightful talk on nutrition, disparities, and cardiovascular health promotion. Dr. Williams, the floor is yours.
Thank you so much, Dr. Kaura and Dr. Cook. I really am humbled to have taken the position at an institution that really has the right approach to the issues that we have facing us, many of which I'm going to talk about today. As Dr. Kaura has mentioned, my passions are really about health equity and nutrition, and there's more and more interest, I'm glad to say, around the world and around this country, but it's very palpable here at University of Louisville. And so I'm going to start off by really talking about what really is our issue in the United States. And that is that we really have a system that has been broken for a while. And that system is extremely expensive. And you'll hear the term toxic levels of healthcare expenditures. And what are we getting for it? You notice that our life expectancy actually peaked in 2014 and then started to go down. And what is in the way of making this worse or allowing it to get worse is basically everyone in this room. And so I'm glad you're here, and I'm glad that we're going to talk about some of the issues and how I feel we can go forward to improve what indeed we have. The number one cause of poor health in our country and actually around the world is actually dietary risk or poor food habits. And I'm going to show you a lot of data that's going to underpin this issue because I think it really is the solution to many of the problems that we're having in health. It's not going to solve all of our social ills, but it's going to get us moving in the right direction so that people will at least live longer with less disease. You're going to hear a lot about social determinants of health, not just here today, but this is going on and on. But when you look at what Healthy People 2030, for example, are talking about in social determinants of health, you'll hear a lot about food insecurity. I'm not sure that that's going to be exactly correct. That is, there are plenty of people who have plenty of food. The question is, are they eating the right things? Is it contributing to their health or contributing to their illness? In the United States, we have plenty of food. And that food is essentially making us sicker and sicker. We have a very long food chain from production to advertising to sales. And that long food chain bends toward chronic illness. And we have to wrestle with this data and then try to fix it. So when we look at the burden that we have as adults, young adults, teenagers, the amount of overweight and obesity, prediabetes, fatty liver, it's actually going to be overwhelming. And that toxic level of healthcare expenditures that I was mentioning really is only going to get worse. And when you just look at the bottom line, $160 billion just for diabetes alone. What could we do with $160 billion? Well, people argue back and forth about forgiving tuition loans, but how about lowering or eliminating tuition for poor people? How about roads and bridges? There are so many things that we could do as a society if we weren't spending it on unnecessary diseases. Obviously, it's not fair to talk about major issues in healthcare during a pandemic without mentioning the pandemic. And it really has been, I think, correctly characterized as a fast pandemic on top of a slow one, because it turns out that everything that we have seen with COVID-19 says that if you are a person who has the risk factors for the cardiovascular disease and chronic illness, you actually had a worse outcome with COVID-19, whereas the people who are eating a whole food plant-based diet, they're exercising, not diabetic, hypertensive, not overweight, have actually really not that bad a time. Remember when coronavirus was just a cold virus. That's what it feels like to them. Now, this issue of people of color having a worse outcome with the COVID-19 came out very early. Within just a couple of months, everyone was seeing that this was a huge disparity. And people were trying to figure out, is it really about the genetics of people of color, or is it something else? And we collected data at Rush, but I can say that the people at Oceaner Clinic published it before we did. And so in New England Journal of Medicine, but we got about the same result. And that is the mortality among our Black versus white patients really wasn't about race. It was about risk. If you did an adjustment of the population that you were studying for the risk factors and the socioeconomic factors that are underpinning the population, what you found that Black race just slightly was actually protective. We found that at Rush as well in west side of Chicago. And so those hazard ratios really drop when you try to take into account the socioeconomic and clinical characteristics that the people have who end up with a mortality. Well, and that's because this was really on top of that slow pandemic. The burden of cardiovascular disease in the United States, for those of you who have been doing this for a while might not realize that it's been the leading killer of Americans since 1918, where it was taken out for 1 year by the Spanish flu epidemic. That fact did not change with COVID. COVID, we thought it was going to take over as #1 cause of death, but it actually missed by a little bit. And so we're still here with cardiovascular disease being the leading killer. And if you look at that last bullet point, a lot of what we're dealing with in Louisville and around the country, particularly in urban areas, is that our African-American population has a very disproportionate degree of cardiovascular disease, over half of Black adults having some form of cardiovascular disease, and that 21% higher mortality rate, which I'm going to talk about a little bit as we go on. Now, How about all of you? You can take a look at what we're doing, the developments that we've made, particularly in cardiovascular medicine and primary care, trying to get door-to-balloon times and systems set up to try to improve cardiovascular outcomes. And we've done a lot, about a 70% decrease in cardiovascular mortality over about a 40-year period. The problems are multiple here, though. Number one is that the progress that we made stopped in about 2015. And that not every portion of our society has benefited the same. As you can see, this is about an 11-year difference in outcomes between Black folks and whites and in our society for cardiovascular death. And it isn't just Blacks. I mean, if you look at what happens with Native Americans, if you look at Hispanics, we have this disproportionate degree of cardiovascular mortality that goes beyond just race. And what's similar, it's really that health status is very much tied to socioeconomic status. And that really is what's combining our situations. And so coming to Kentucky and learning a lot more about what Eastern versus Western Kentucky, they're very different areas. And most of you are very familiar with the fact that Appalachia, I had to learn how to pronounce it as a Northerner, as it turns out, has an extremely high burden. I mentioned Blacks, 21% higher. In Appalachia, it's actually 33% higher cardiovascular mortality. And it's the kinds of things that you would imagine: the doctor shortages, unhealthy, stressful lifestyle and risk factors, low levels of education, and poverty. And so what are we going to do about it? Well, making observations is first. If we don't measure it, we won't be able to modify it. And so this, you might notice, was published this morning, American Journal of Preventive Cardiology, about that exact same issue around the country: socioeconomic status, cardiovascular risk profile, and premature coronary heart disease. And what the authors were trying to get at from a large database was that if you are poor, if you have lower levels of education, you're going to have a higher odds of not just coronary heart disease, but coronary heart disease in young or middle age with a factor of 8 or 9 times higher. And so this was just some of their data talking about income on the top and talking about education on the bottom. The lower levels of education, the lower levels of income are uniquely associated with poorer outcomes and a more rapid development of cardiovascular disease. Well, this one was actually published a couple of weeks ago, and it's really an interesting point of view, published in the Journal of American Medical Association, trying to figure out what is it that we could do to achieve diagnostic and therefore therapeutic cardiovascular equity. Well, it's a wonderful article to pull and dissect. I'm actually going to do that, using it sort of as an outline for a lot of the things that I had to say anyway. And their conclusions are very, very true, that racism, sexism, poverty are the issues that result in marginalization of people. And so you end up with less rapid diagnosis, and you end up with, therefore, less ability to intervene and make things better. We have inequities in healthcare access. Now, I look at that a little different. People will say, yeah, we have problems with access, and it's structural racism and it's and inequities that are driving it. But I would say that this is playing out in so many ways that we have to actually look at it very carefully. This is an article that we published and presented American Heart Association a couple of years ago from my time at Rush and partnering with one of our residents who ended up at Loyola. And the data was actually very clear. That is, we have a wonderful guideline-driven test that is coronary calcium score. The problem is with coronary calcium scoring is that unless you're in Texas, you actually have to pay out of pocket for it. Well, that may be not a problem for the CEO of a company to pay $50 or $100 out of pocket. But for our poor population, that's really going to essentially mean a denial of access to care. I started this project really because I thought Rush was charging too much at $95, and I wanted to show them that this getting people to choose between food and rent and a CT coronary calcium score wasn't a good thing. We could do better than that. Well, it turns out that it wasn't just Rush, it was all over. And we ended up with a publication almost a year ago that really talked about the fact that this is a guideline-driven test, that it's proven its value to our population for screening, particularly if you have that risk calculator on your phone for ASCVD 10-year risk, and it's between 5 and 20%. And that person doesn't have a known coronary disease, that this is a really good test that'll drive management, and it actually drives patient behavior as well. Well, it turns out that there are a lot of places in the Chicagoland area that actually don't even offer it. And all you need to do in order to have a hospital near you that doesn't offer it is to have a low household income, a higher level of poverty, a higher population, lower levels of higher education, and that all wraps up into a lower life expectancy. So diagnostic testing can correlate with bad outcomes. How about symptom recognition? Well, what is that? That really is health literacy. And if people are not understanding and don't have access to care to us, where our doctors, which of course in Latin means teacher, has familiarized them with the healthcare system and their own physiology and pathology, so they understand when they really need to seek care, they're going to have later presentations. And this disparity is something that we could overcome with public education. How about bias in the provision of timely and optimal care? Again, this is a manifestation of structural disparities, and it's not just Blacks, it's any underserved population socioeconomically, this plays out. Then we have the issue of implicit bias. And I'm going to spend a little bit more time talking about this one because it's something that we could just look in the mirror and we could change this really in a flash. But the fact of the matter is we do have this. It's been around for a while. It's particularly an issue of African-American women, where we actually lose a little bit of our diagnostic reasoning based on the race and gender of the patient that's in front of us. This was very famous. Serena Williams, for those of you who weren't watching the US Open last night, she came up with a marvelous win. Well, little do people remember that she had pulmonary embolism in 2011 after a foot injury and being in a cast. Well, she knows what her symptoms were like. And when after her delivery, when she got the same symptoms, she tried to tell them, I think I have a DVT and pulmonary embolism again. And they didn't believe her. And that turned into a nice television show. That's Miranda Bailey, for those of you who are Grey's Anatomy fans, really playing up on the same thing because it really is an issue. What is it? And everyone was sort of shocked to find out that there would be bias in our modern society against African-American women. But the data has been out there for a while. This is almost 24 years ago, where the New England Journal of Medicine actually published 8 actors, young, old, African-American and white, male, female, and gave doctors an opportunity to listen to their stories, except it was exactly the same story given by actors of what sounded like unstable angina, all of them giving the so-called positive Levine sign of a closed fist over their chest. And despite giving exactly the same story, the odds of getting the appropriate urgent cardiac catheterization referral was dropped by 40% if you were a woman. It was dropped by 40% if you were a African-American. And if you were a Black female, the odds of you getting that referral that everyone else was getting was going to be about a 60% reduction. And so this New England Journal of Medicine article really, I think, started the push towards trying to deal with implicit bias, but I don't think that we have removed it, not yet today. So that the Sakar article that I've been talking about and using as an outline so far really does make a lot of recommendations. And it's talking about training people, using decision support. One of the things that was very helpful in cardiovascular arena is to do all the reviews as a group of who's going to get surgery and who's going to get medical therapy. Do it in a group where the race of the patient is never discussed. And that's really helpful. But we need to do other things. We need to lower the financial toxicity of our healthcare system so we're not disenfranchising the poor. We need to continue to enhance symptom recognition, which is basically done through public education. We need to have more trust between the community and the people who are trying really hard to care for them. One of the ways to do that is to have a more diverse health care workforce, and that really means improving our pipeline so that our doctor percentages look similar to our population percentages, which is an ongoing problem that's been there for really generations. So we really do need to improve our system in so many ways. But I want to spend a moment talking about healthcare access, because we've got this triple aim, which was put out by Don Berwick and years ago, and improve health, lower cost, better care. And of course, we try to keep making it better. And one addition to the triple aim, the quadruple aim, is having a physician workforce or a healthcare workforce that's actually healthy. And that is going to be so important going forward. And we're, as a department, are working on that. And we, if you were at the faculty meeting yesterday, you know that it's one of the foci of the kinds of things that we're going to try to do as a department to move forward. But there's a fifth one, and that is the health equity that also needs to be in there for optimizing care in this country, not just lowering costs, better care, and improving health. So if it's not just access, what is it that we're talking about? Well, there are issues of poor access to care. The longer waits, fewer providers, not getting that coronary calcium, because it's not available, less subspecialty care in our minority population. But on a twist of words, I would say that it's not just poorer access to care, it's access to poorer care. As a guideline writer, we've been very frustrated with American College of Cardiology, American Heart Association guidelines. I've done hypertension, nuclear, and most recently, primary prevention. And when you look, if you just biopsy the charts, you can, or look at the scans that are done at outside places, our quality metrics are really not being met. These are things that we could do. We need to, and the universities actually do pretty well with this, but not every specialty follows the guidelines of other specialties, even though we're responsible for their care. So we need a lot of cross-correlation of guideline-driven management, continued education, and then diffusing it out of the universities where the care is pretty darn good to the communities. And I know that university health does that in a very large way. And now that we have 200 sites and a lot of academic focus. So that adherence to guidelines from the providers is really going to improve the quality of the care when people do access it. The third issue that we have to deal with, instead of not just poor access to care and accessing poor care, but accessing care poorly. What do I mean by that? Well, the doctor might tell the patient what to do, but if they don't have that relationship, or the patient doesn't have the trust in the physician, or in some cases, it's just the health understanding to be able to actuate what that advice is all about, you end up with the poor lifestyle choices, and you could get good advice and then do very poorly with that advice. So when people say access to care to me, I'm thinking, which one are you talking about? We need to work on all three. Another article that I'd like to focus on that was published a few days ago is very shocking, and it's something that we all have to get in the middle of. And that is the projections of what's going to happen in the United States based on the disease burden and the trends that we're seeing. And this is the, the Journal of American College of Cardiology always has a central illustration, but this one is a little hard to digest unless you just stare at it for a while. So I'm going to summarize it a little bit. and just show you some of the graphs. What they're basically saying is that all of our risk factors between 2025 and 2060 are going to go up tremendously, particularly diabetes. And the result of those risk factors going up is going to be a substantial increase in the heart disease manifestations that we see: heart attack, heart failure, stroke, and overall ischemic heart disease. The shocking projection is based on current trends that all of these will actually decrease in the white population, but will increase in the racial minorities. And since our population is changing, that by 2060, there will be the minorities are no longer going to be minorities, it turns out that that will increase the level of diabetes, hypertension, obesity. You can see the red line versus the decreasing blue line, red line increasing for every risk factor and for every manifestation of those risk factors in terms of pathophysiology. And so what will that actually do? Well, it's going to increase our healthcare disparities. It's going to impoverish, because if you don't have health, you don't have wealth. You have no chance of having generational wealth if you're spending most of your time dealing with chronic illnesses or sudden cardiac death. And so, but I want to point out that the authors are looking for, for the social improvements and social programs and better treatments. And I would like to spend the rest of the time talking about the fact that everything I'm hearing so far from these major articles is talking about improving the management of disease. And we're really talking about essentially mopping up the floor instead of turning off the faucet. How about prevention? Why aren't we stopping the development of disease? What would be the impact on our society if our sick population just wasn't sick? And is there something we can do about it? Well, the data has been out there for a while. Now, this was one of the more shocking ones. If you can see the upper left-hand corner of your computer screen and see that August, this is about a month into the pandemic. There were people, particularly at Physicians Committee for Responsible Medicine, coming out and saying, hey, we know that it looks like the obese people, diabetics, et cetera, are getting more ill with COVID. Now we actually have a situation where everything we've been saying about plant-based nutrition to improve our health for all of these risk factors is actually coming home to roost in terms of COVID-19. And the real issue is that we have dietary guidelines. It says that people should be doing 3 cups of vegetables per day, and 90% of Americans actually do not do that. If you look at our nutrition, really our nutrition deficits as a country, they're actually worse in our ethnic population. And so 21% of African Americans getting the fruits and vegetables that are recommended. We're way less likely in the Black population, and even so much in the Hispanic population to meet those guidelines. And if you look at it, really isn't just about race. If you look within, and I'm going to show you some data in this regard, that compare Black people who are eating well to Black people who are not eating well, there are huge differences in disease burden and outcomes. But what do we have? Right now, we have this burden of obesity, which I'll focus on for a couple minutes. It's particularly true of African-American women, and it's actually up to 80% if you include overweight, that is a body mass index of greater than 25. And Kentucky is one of the states where the over 35% of our population actually is obese. But this is with including everyone. If you break it down to the white population, it's still true, but it's only in Kentucky, but it's only a handful of states. If you do Hispanics, that number of states more than doubles. And if you look at the African-American population, it's almost every state. And so what is it that's going on? Do fast food restaurants actually focus on poor communities? Yes, they do. They always have. It's a marketing strategy. And we have a population that's not familiar with the kinds of dietary interventions such as Dean Ornish, plant-based nutrition, that can result in sustained weight loss. And the dietary patterns, it's not just calories, it's actually the dietary patterns as well. It was called out by the REGARD study at University of Alabama, Birmingham, where they talk specifically about all the American types of diet and this probability survival Kaplan-Meier plot falling off of a cliff really is for the so-called Southern diet. That's a kind of a nice way of saying soul food, things that are fried, taking your greens and putting ham hocks or neck bones in it, sugar sweetened beverages. Yams are great, but candied yams, not so great. And what is the result of that Southern diet? Much higher heart disease, much higher kidney disease, and much higher stroke rates. Now, if you were to just try to dissect out with statistical modeling, what would happen to our African-American population if they weren't dependent or eating bad types of food, that Southern dietary pattern, it would cut it instantly in half. I'm not so sure. I think that's a bit of an underestimate, actually, but this is something that we have to at least investigate, change the diet, see if we can change the outcome. I don't want to go too far into the idea of microbiome, but I have to mention that all of the data about hypertension, high cholesterol, diabetes, and obesity is pointing to the fact that your diet changes your microbiome. And so I will have to be asked to come back and give another talk on cardiovascular nutrition that'll focus predominantly these days on the microbiome. The fact that we are not all human, we're actually only 43% of the human body is actually human. And we have a variety of microorganisms, particularly bacteria, that help us or hurt us in terms of digesting food, changing how we deal with drugs that are taken, change our immune system. And a bad microbiome, having bad bacteria in your GI tract, actually promotes neurologic diseases. And it turns out it's all of our cardiovascular risk factors as well. So I show this one to say that, I know there are folks at UofL who actually are working hard on this microbiome. We want to promote that because that seems to be the way of the future to interfere with the risk factors that we have. And the best way of dealing with it that I know of so far, reviewing this literature, is the prebiotic concept, which is eat the right food. If you do that, you're going to improve your microbiome and you can actually decrease the amount of obesity with multiple mechanisms shown on this slide. I encourage you to take a look at it, download the slides, take a look at it. Because the data is very clear. The amount of data on obesity and diabetes is increasing. We know which bacteria actually increase diabetes and which ones decrease it. For hyperlipidemia, none of us were ever focused in the lipid world on the ISMA gene, which is part of the genetic makeup of good bacteria in the GI tract. They can actually change your cholesterol to carprostenol. It ends up getting excreted instead of ending up in plaque. How about hypertension? Absolutely. The good bacteria and a good diet result in short-chain fatty acids and anti-inflammatory immune cells that reduce vascular resistance and blood pressure. And so it turns out that that connection between food and blood pressure that we've known for years really does make microbiological sense. Now, in addition, we have to mention the microbiome and the Cleveland Clinic's trimethylamine N oxide. If you haven't seen the TMAO data, please take a look. This is New England Journal of Medicine almost a decade ago saying you eat animal products, it gives you choline, phosphatidylcholine, which is turned into trimethylamine, which you then oxidize to trimethylamine N oxide, and that correlates with heart attack, stroke, death. But now we know it's much more than that. It's heart failure. It's actually cerebrovascular disease, and it's actually kidney failure as well. So this data is really increasing. What it does is it puts into perspective the data that we've had for a long time, saying that basically there are no safe animal products for cardiovascular health or overall mortality. This is Journal of the American Medical Association, the Harvard group, talking about nurses and physicians. And if you look at the data, what would happen with their modeling if you replace animal protein with vegetable protein, even just 3%, you would see a statistically significant decrease in mortality, more so for processed meat than eggs, more than red meat more than dairy, poultry, and fish. But again, no real safe animal products. Now, I'm going to take this in a slightly different direction because many of you have seen this already. Okay, relating all of that I've been talking about in terms of health equity and equality, they really are not the same. Giving everyone the same equal amount of support doesn't actually get the job done. And so you've seen this one before, but I'm going to give you just a slightly different take on it. Here's one different take. The difference between equity, equality, and reality, where those who have get more in our society and those who have less have an even worse outcome. But I would like to actually put a fourth one in there that I think people are starting to recognize that what we really do need to do, instead of trying to give everyone the support they need to get over a barrier, why not just remove the barrier? And so how does that relate to the talk today? Well, we are committed as a university to this idea of anti-racism agenda. That means that we're going to adopt everything that we can to become anti-racist and to try to remove the kinds of barriers that are resulting in the disparities that we have that limit our entire society. People don't like me saying it, but if you have a system where you have emergency services that have to be paid for, and you have a system that is reducing the level of education and economic viability for generations because of racism, and then you put on top of that poor food habits that result in more chronic disease, you end up with this cacophony of results of an expensive healthcare expenditure that the tax dollars from the community, the poorer community, actually can't bear. So we all end up paying for each other's healthcare. That's my point. And so we do need to understand that. Yes, in terms of inequality, injustice in healthcare is the most shocking and inhumane. And I would like to propose how we can move forward. Let's remove the barriers. Let's do more in terms of promotion of healthy diet. The first thing we need to do is to get rid of the junk food industry that's being subsidized by our government. Then I don't like calling out any particular products but Hostess Twinkies, 14 different ingredients that are made and subsidized by our government, high fructose corn syrup, so that we can end up paying for the illnesses that occur thereafter. My next target would be television advertising. This is an article we published last year talking about the fact that our fast food commercials show very unhealthy items. It's much worse than grocery chains and brand recognized individual items or home delivery meals, which are a negative score if you look at the literature underpinning it, but not as bad as fast food. And these television commercials are very dangerous because of what they do. And this is why we have legislation against cigarette smoking. And we've tried in other countries to ban unhealthy advertising to children in Canada, European Union. Why not here in the United States? Why am I talking about this in healthcare disparity talk? Because there's a link between television watching and poverty. That's very strong. It's a linear effect. The poorer you are, the more television you watch. And this is something that we have to really consider and try to make some impact. So how about the food desert issue? And yeah, people have been talking about this forever. And I just give you a slightly different take on that as well. Healthy foods not being sold in local stores. When I got here to Louisville, they were saying it's not a food desert, it's more of a food apartheid, because it's really not that far. It's just you got to be on if you're west side versus east side, it's very different. That's true. And so the more wealthy neighborhoods having healthier foods, understandable. Some people say, no, it's not an apartheid, it's a food swamp. And then the environmentalists get upset because swamps do so much for our planet. So we probably shouldn't use that term. So I'm looking at those Twinkies and I actually want to change the jargon to a food dessert. Honestly, that is, we have unhealthy food preferred by customers of grocery stores. Grocery stores are in a business. If they don't sell what people are going to buy, they go out of business. So the issue is us. We are the problem, not the stores. And this is something that we can deal with only by education of people. What are we going to educate them? I would like to promote the 2019 Primary Prevention Guidelines, Section 3.1, talks specifically about the cornerstone down in the left side, which is diet. And it emphasizes more fruits and vegetables, more nuts and beans and whole grains, and getting rid of saturated fat, reducing sodium and cholesterol, getting rid of processed meats, refined carbohydrates, sugar-sweetened beverages, and of course, no trans fats. What happens if you actually do that in our Black community that we say is so bad cardiovascularly? Well, the data has actually been published for a while. This is from the Adventist Health, where they could compare Black versus white, good diet versus bad. And what they were able to find is similar to what I showed you before about the regards. If you do a healthy diet and you're Black, doing a vegetarian or vegan diet, you end up with tremendously lower hypertension, hyperlipidemia, diabetes, and that has been played out not just observationally, but prospectively. I'll show you 3 trials done at Rush and at the Montgomery Wellness in Houston in the Black population, showing that in Houston, it was a 4-week intervention showing a reduction in risk factors, including Lp(a), which people said doesn't respond to diet. It definitely does, at least in the Black population. A second publication from that same group showed all of the risk factors that they measured and improved tremendously. That dovetailed very well with the improvement that we found at Rush University doing a nutrition intervention for 5 weeks in President Obama's old church on the south side of Chicago, where we took the ACC-AHA 2019 primary prevention guidelines and did an intervention, fed people, delivered food, please don't eat anything else. And the result was actually tremendous, which is that insulin levels dropped, the TMAO levels dropped, every risk factor improved significantly. If the compliance was actually quite high, the weight loss was tremendous. And if you took our risk calculator that I mentioned and put the old versus new data into it after the 5 weeks, 19% of that 21% increase in African-American adults in terms of outcomes was actually eliminated. Now, obviously, you have to do more than just a 5-week intervention. And we actually published a cookbook that you can download from the Association of Black Cardiologists called Heart and Soul. Just Google it and you'll see it, or send me a note and I'll send you a link. Well, we made the news, but did we really make a difference? I would like to say that we make a difference by going forward. The best way to predict the future is to create it. That was an Abraham Lincoln, and people talk about, Emancipation Proclamation and Juneteenth. And the fact of the matter is, we are still eating in the African-American community the kinds of foods that were putting us in, that we had no choice during the time of slavery. And now we do have a choice, and we have to try to change the nutrition habits of our community. To that end, I'm glad to promote the fact that the White House has taken this up for the first time in 50 years. They're actually doing a nutrition and hunger and health symposium. They asked me to be on part of the task force, and I was telling them some really things that you could imagine based on what I've been talking about this morning, that we want to stop the congressional subsidies for unhealthy things and get the congressional subsidies to go towards producing fresh fruits and vegetables like Finland did to remove so much of their cardiovascular disease. We need more education of people. We need labels that improve the selection of our patients. And these have been done in other countries as well. And stop television advertising for fast food. Well, the report is actually out. It came out a few days ago, so I encourage everyone to take a look at it. I'll just summarize it very quickly before I end. And they did take some of my recommendations and put them in there, try to improve the SNAP program, try to eliminate food insecurity by making sure that people have access to financially to better foods, to try and spend our money on SNAP instead of food subsidies that are for people making unhealthy foods. Try to improve the labeling. And so we make 30 different recommendations, all of which are going to improve the health of the society. Now, whether the White House will take them all and make them all, turn them all into action remains to be seen. But that conference is going to be on the 28th, and I'm looking forward to the outcome of that very much. So in summary, I would say that nutrition, in my view, is the crux that of our healthcare disparities that we have. And we're still going to have the disparities. I'm not saying that we're going to fix all the socioeconomical issues that we have in this country and racial bias and all the things I've talked about just with nutrition. But what I would say is that if we could just tamp it down some, if we could get the cardiovascular disease and stroke mortality to go down, get to lower levels of economic impact on our communities, that we're going to do so much better. And this is going to be an opportunity going forward for each of us to take on, whether we're in the clinic or whether we're in the state capitol or in Washington, D.C. We should be advocating and educating, and this is really our responsibility. This is what we need for our patients, for ourselves. We need it for our communities, and we need it for our country. And with that, I'd like to open it up. Now, before talking about just questions and answers, we're hoping to do it into 12 minutes of brainstorming. I'd like your ideas on what it is that we can do to make these things better. I'm happy to answer questions as well, sure, but I'd love to get your ideas and your feedback.
Thanks, Dr. Williams. That was really powerful, very insightful, and really striking in the way sometimes that the best answers are the simplest answers, right? I'm going to editorialize a little bit here. So I recently saw a documentary, and I would urge everybody to watch it. It's by Kate Winslet. It's on, I think it's on Netflix, and it's called Eating Our Way to Extinction. If what Dr. Williams showed you for cardiovascular disease prevention wasn't enough, that adds another angle. We're heating up the planet and causing all this climate change because of agribusiness. So once you see that, it's really powerful. We're not just going to improve human health and disparities and all of that. We're just going to save our planet too. So I watched it recently. I didn't know enough about it, so I would urge all of you to watch it. But getting back on point and talking about disparities and ideas, I think calcium scoring, as you mentioned, is a great way to go. And myself and the radiology department, under your guidance, are going to try to expand appropriate calcium screening to patients that are in need. I know Dr. Sadler is a big proponent, most of my division is, so we want to work with you on that. So thank you so much for this awesome lecture.
Well, I appreciate that very much. Talking about eating to extinction, I'm going to watch it right away. I actually do have those slides, and I took them out for this particular talk. And it's the one that says, you know, what's the mortality rate from eating beef? And the answer is 100% for the cow. Okay, but it's more than just animal rights. It really is a planetary sustainability. And we'll hire an electric, or we'll buy an electric car, but then still eat a steak. And it turns out that the carbon dioxide emissions from cars is 23 times less than impact on the environment than the greenhouse gases developed by the animal industry. So I really appreciate your pointing that out. In terms of coronary calcium score, absolutely. And we need as many volunteers as we can get to go to, we're going to do the churches on the West End and, the football games, the basketball games. and use our risk calculator. And anyone, like the guidelines say, between 5 and 20% is a good candidate for coronary calcium scoring. And so I know we're going to have to do more pulmonary, more vascular surgery, because you're going to find those 5.7 centimeter aortas and those 5 centimeter nodules. And that it's a pretty powerful test in many ways, in addition to heart disease. So thank you for gearing up for that. Dr. Stoddard? Is that right? I think you're on mute. I see your hand up, though.
You hear me now?
Yes.
All right. Sorry. Great talk, and learned a lot from what you discussed. And I just wanted to harken back to my experience probably over 30 years ago. I'm sorry. All right. I just wanted to harken back to my experience in this area. And you mentioned very briefly the cookbook. And I just wanted to emphasize that in the African-American community, taste rules. So if it doesn't taste good, I don't care if it's going to help your cardiovascular outcome, you're probably not going to make a major impact. So to change dietary habits, you have to have food that is appealing. So I would also suggest that when you go out to these areas, if your cookbook is great, have samples of the food. And if they sample it and like it, that would then encourage them to use or eat that kind of that vegetarian type diet. Otherwise, it's going to be a uphill battle, I think. And I've sort of confronted this firsthand. My wife, who's a nutritionist and dietitian, actually did the same thing years ago, coming up with ways of preparing foods, substituting things that were healthy in terms of the preparation and cooking of the food that made a big impact. And I love the taste of it. So I think I just wanted to emphasize that as an important factor.
So thanks, Dr. Stoddard. I mean, let me just comment. Well, the point that you're making is a really good one. There's a movie out from a few years ago called Invisible Vegan. It's about being Black and vegan. It's mostly geared toward the African-American female experience, but I think it counts for all of us. And they make the point that, people think that plants don't taste as good as animal products, but every animal product that you eat, you put some kind of sauce or some kind of seasoning to make it taste more like a plant. so that makes your point that you really can take plants and make things tasty, because that's really what humans want. I have to admit that I've always tried to push on the other side of the equation. I will sit with my patient, and it's a little easier, not for primary prevention, but secondary. So I'm seeing people in the coronary care unit and the like, and I'll try to, work with them. And I say, you are going to determine with your meals and with the food that you're consuming and your lifestyle, your exercise, how long do you want to live? How sick do you want to be? How much living do you want to have during your life? That is, how functional do you want to be? And question number 4 always gets them: is there any food that tastes better than your health? Now, the interesting thing is that my experience is that people will say, no, there's no food that tastes better than my health. But what you're saying, Dr. Stoddard, ends up being the functionally the real issue. If it doesn't taste good, they're not going to be as likely to do the healthy stuff. So agree, and hopefully you'll find that the ABC cookbook has plenty of very good tasting items in it, geared toward sort of a healthier version of soul food without the animal products, saturated fat, and cholesterol.
Dr. Williams, are you able to see the chat? There are a couple of questions and comments there for you, starting with Dr. Earnshaw.
Okay, so I see 89. So maybe you want to give me a head on where to start. Oh,
I will. Start from the bottom. Dr. Earnshaw's comment that says, "Thank you. It's refreshing to see a leader focusing on common sense solutions to our healthcare disparities. Please improve curriculum in medical schools so that future doctors know how to counsel patients on diet, collaborate with our dietitian and nutritionist colleagues in a team-based approach to preventative medicine in clinics."
I really appreciate the comment. The best place to start is to look at ourselves, because cardiovascular medicine is huge. We have a publication that's out. You can Google it. Steve DeVries was the first author. I think I was the senior author, where we actually ask American College of Cardiology members to talk about their comfort and their understanding of nutrition. And we were very disappointed to find out that 1% of our FACCs, Fellows in American College of Cardiology, and 0% of our trainees felt like they had enough nutrition education to be able to counsel people. That sent reverberations through the college. It hasn't always changed, what we're actually even feeding doctors at conferences. I will not, mention the conference that was here in Louisville a few weeks ago, American Society of Preventive Cardiology, where they were feeding bacon and eggs and sausage to the doctors. And we really do need to change everything about our nutrition education system. So I appreciate that comment. I'd love to look at our curriculum here at University of Louisville and be one of the places that makes a difference. The other side of it is the hospital. We're making incremental changes. Just a handful of hospitals have actually adopted the 2018 AMA policy on hospital food because that same thing was happening. You put a stent in someone, you come back to see them the next morning and their tray has bacon and eggs. And I understand that that is the business model that it was helping, but that is not our intent. I guarantee that's not our intent. And so we can do better in every institution. And I think our White House conference is going to really emphasize that. Let's see, I see Dr. Emmons, Robert Emmons. Okay. Mentioned television, how to stem the tide of social media. And polarization and health issues. And this is really, you're pointing out some really important stuff. And that is social media and television are actually changing how people look at things. We have people, going back and forth about global warming. They're pretty much convinced in London and with the heat wave this summer and Germany with the floods a few months ago that the globe is changing, no question about that. But the issue of the vaccines is very sore in our population. There was a publication, British Medical Journal, a few months ago that made it very clear that vegans don't get sick from COVID. No vegans apparently died of COVID. That can't not be true. That can't be true, but apparently it is true. But the odds of a vegan getting sick from COVID was reduced by 73% in this. That was a 6-country healthcare worker population that was studied. Well, that actually had some downside, some major downside, and that the vegans saw that they weren't getting sick and they were going around saying, don't get the vaccine, not recognizing that's the vegans. Those are the people who you really need the vaccine. You need the people who are going to get the illness, not know it, have zero or minimal symptoms, spread it to some kid who will give it to his grandmother. So I agree with your point. That is, we need somehow to maintain a higher level of education and understanding of impact before we go on television or we go on social media and say things that are actually going to harm the health of the country. Oh, so if you're in the chat, I see the Dr. Bishop has uploaded the link, Eating Our Way to Extinction. I'm definitely going to watch that one. Dr. McGee asking about plant-based meat alternatives and possible and beyond brands. I would say just go with the 2019 ACCHA guidelines. There are some really healthy black bean burgers and healthy meat substitutes, and then there are ones that don't have good things in them. Saturated fat and sodium are the usual culprits. And so Impossible Burger actually has one more thing, which is heme iron, which is associated, according to the NIH studies, with increased mortality. And Beyond Meat is actually, I actually talked to those folks and they said, oh yeah, we're gonna try to change it. It looks like they have. So please, whenever you're looking at a plant-based alternative, just flip it over and look. If it's more than 300 milligrams of sodium, maybe your tolerance is a little higher if you're not African-American or don't have a tendency to hypertension, great. It has more than a couple of grams of saturated fat, I really would avoid it. Okay. Dr. Dryden, I really like that one. How about the ACB cafeteria? I really, you don't want to make a lot of waves when you walk into a new institution, but this is the kind of thing I would love to do, to start right at home in every cafeteria and every hospital meal. It took a long time, and I'll admit that if you follow me on Twitter, you saw a few days ago that Rush changed their menu to include way more plant-based stuff. I've been trying for 8 years there, not a lot of success. And it was actually a medical student who came in and wouldn't let them go until they made a difference. And they make some really good points about Press Ganey and expense, but ultimately, you can do the right thing, and that's with education. And it turns out that the data is very clear. You don't lose Press Ganey points by telling people that we're feeding you. You may not like it at first, but we're going to feed you food that's going to make you healthier. It actually makes your Press Ganey scores go up.
Looks like Dr. Murphy has her hand raised. If you can unmute, go ahead and ask your question.
Hi, thanks for such a great talk. One comment or plug that I wanted to give. So I feel really strongly that, organic and even biodynamically grown food that's local is both the solution for environmental crisis, but also for our health and our microbiome. There's an organization in Louisville, if anyone on here hasn't heard of it, and just something good to familiarize yourself with and even refer patients to. There's a really good website. It's called Change Today, Change Tomorrow. And there's a program called Feed the West, where it's actually a CSA with organic produce that gets delivered to folks. And they include like hygiene products and infant products in the CSA shipments. So it's really focused on just breaking down barriers to access. And then I wanted to kind of build on the comment of Dr. Dryden that we need more nutritional counselors. And I feel this a lot in the primary care setting, where you have a patient with obesity, with heart disease, everything, very quick discussion. You find out they don't have great nutritional habits, and you don't have enough time to talk about it. And we have, Beth Ackerman, who, is under the Division of Endocrinology. She's an incredible nutritionist, and she does a wonderful job with our patients. But, they have to set up a separate visit to come back for another appointment with her. And if we could break down any barriers to have the ability for A, giving her some partners and extra support to build on what she's already doing, but B, even drop in nutrition visits in the HCOC. I feel like that could be something huge for our patients, and, build on maybe other future ancillary services that we can offer on a drop-in basis.
Well, thank you, Dr. Murphy. This is really important points that you make. Obviously, in the cardiovascular arena, we are still waiting for the difference between organic and not organic. We know it helps. We don't have data on heart disease yet, but I know it does help the planet. Okay, so that's really important. And now they have 9 grandkids. I think the planet is pretty important. So the other aspect is that we have struggled, to be honest, with our nutritionists around the country. They have not all bought into what the American Academy of Nutrition and Dietetics are saying, which if you go on their website, they say vegetarian diets to reduce chronic disease. And yet we have people, even though the data has been out there for probably 3 years, that animal protein kills kidneys, we have the nephrologist having nutritionists saying that you have to eat red meat, even though it's the cause of the disease and increased mortality. So if we have someone who's progressive and following the literature, that would be great. And the answer to the access question, one of the major answers is group visits. That is, and when the patient comes back for another visit, do 10 or 12 people together. People banding together tends to improve their diet more than when you do the counseling individually, because they start to rely on each other. They develop friends, and it's like you're all in this together because you really are. So I'm hoping that we can set that up. It'll be great, and I'd love to meet with our nutritionists and talk to them about the evidence, and hopefully they have it all already. But if they don't, I'm happy to share.
Dr. Gafgazi, did you have a question?
Yeah, thanks for the talk. Excellent talk. So, we do obviously run, especially in cardiovascular medicine and all internal medicine, evidence matters a lot. So we have, a randomized trial for Mediterranean diet. We have a trial for walnuts. We've never really had any trials for vegetarian or vegan diet at the size that, you get published in New England Journal with 4,000 patients. Those trials are difficult to do. And when it comes to diet, I'm sure it's going to be very difficult to do. But, the size of the effect that is suggested is so massive that it's worth doing. Are you aware of that happening?
So this is what I'd like to do. You can be my co-author, huh? So you're making up the prospective trials that I've shown you here were 40, 50 patients. And if you don't have a large amount of data, you can't even talk about it in a guideline group. So you're absolutely right, we need this. But let me point out, spend 30 seconds talking about the Predimid trial, 7,000 people you mentioned. But that is the most misunderstood trial I've ever seen in my career in cardiology, in that people came away with it thinking that the 30% decrease in heart attack, stroke, and death meant us, that is cardiology, and it wasn't. And the authors would tell you, the New England Journal of Medicine would tell you, they tried to show it, that there was no mortality difference. What they had was a decrease when you take red meat and turn it into fish. Because there's no difference in cholesterol, it may decrease your stroke rate, but it doesn't decrease overall mortality, cardiovascular death, or myocardial infarction. Now, of course, they're friends of mine. So of course, we were hassling them mercilessly after this wonderful publication that everybody says Mediterranean diet is the best for human health. That's true if you're a neurologist. For cardiology, it didn't help at all. And so we said, well, why didn't you do your perfect trial design and do it plant-based? And they said, well, we kind of did. And they actually published it, and you can just Google it. That is the vegetarian Predimid trial. And what they did was take all of their data, all 7,700 people, and do quintiles of vegetarianism. And it turns out if you compare the worst quintile to the best quintile, it was a 42% decrease in mortality. So obviously that wasn't the initial trial design. It was a post hoc analysis. So even that, you can quote it in your guidelines, but you can't make a class 1A recommendation. So you're absolutely right. The data that we have will tell you that vegetarians live 15 years longer, but it's observational data. Tennis is, another 15 years, and sleep is another 15 years. So if you play tennis, sleep good, and be a vegetarian, you're going to get very, very old. Well, so it would be great to actually have prospective trials that will populate our guidelines. And it doesn't have to be several thousand, several hundred would be a good start. But we need much more data than what we have already. All of the observational data is all pointing in one direction. So we can make a class 2A recommendation on it, and we have. But I certainly am a believer that we need more.
Okay, well, Dr. Williams, we've broken the Williams rule. It's 9:09. Amazing talk to get us kicked off for our Grand Round series this year. And thanks to Dr. Cholera for the introduction, and thanks for all the wonderful participation from our audience. Obviously, this is a topic that many of us are excited about. So thank you so much, Dr. Williams.
Really appreciate it. Thank you so much, everyone.